Next lecture, acute myocarditis, evaluation and management by Dr. Padmanabhan. Dr. Padmanabhan is a senior cardiologist working in KIMS Hospital, Hyderabad. So he's going to talk to us about acute myocarditis. How do we evaluate? How do we manage? See, myocarditis is something which people talk about very frequently but don't find that often. Why we don't find that often is the fact that when it really matters, you don't make it out. Dr. Padmanabhan.
Respected Chairperson Dr. Krishnan Raju and Organizer Dr. Srinivas Kumar, I thank you for the opportunity to be here. Coming to the topic at the fag end of the day, I think I would like to make it very brief. The simple reason being there will be a lot of overlap between what has been talked about in the previous two speakers and what I am going to talk. So I'll be just skipping those slides where there is repetition. So what do you mean by the myocarditis, and what are the situations where you have to suspect this, and how best we can confirm? These are some of the things I'll talk, and how best we can address in treating these patients. So it's basically an inflammatory disease of the heart muscle, secondary to either external antigens or an internal triggers. See, all this or all along, at least I have been thinking that is always something external which can cause. It is not so. There can be internal triggers which can initiate an autoimmune phenomenon. And the diagnosis is by histology or immunology or immunohistochemical analysis. So we have to realize it's not just all of this myocarditis or not just infective alone. There are other causes of myocarditis. Some of them are like HCV can cause. Among the viral, which is the center of my topic for today, the common pathogens are enteroviruses, including echoadeno, and parvovirus has been reported in the past decade or so. Herpes simplex has been implicated in recent times. In the North American continent, Lyme disease is one of the bacterial causes of myocarditis. In the South American population, Chagas disease is quite common. Eosinophilic myocarditis is also quite common, and some of the drugs are implicated like anti-epileptics, antimicrobials and all, including Xyloric, which we commonly use. And another rare cause of eosinophilic myocarditis is dopamine itself, that we have to realize. And if the person develops some rash or a hypereosinophilia on dopamine, it can be a rare cause of myocarditis. So as I mentioned, some of the internal triggers can cause myocarditis. Common among them, which are of clinical importance where treatment will make a difference, is the giant cell myocarditis and sarcoidosis. So if you look at the timeline of viral myocarditis, as I mentioned, next few slides will be basically towards the treatment and diagnosis of viral myocarditis. There are three phases. One is the viral infection place, where the virus gets attached to the myocardial cells and it will replicate. Second phase is the body's response to the virus, where it can eliminate or restrict the viral multiplication, or in the process there it can damage the immune response itself, can damage the myocardium because of molecular mimicry. And the final phase is the burnt out phase, or where the patients are likely to have a cardiac myocardial dysfunction. That is the cardiomyopathy phase. The clinical manifestations are very varied, very simple symptoms to moribund. If it is a minor symptoms, they actually, most of them can actually recover spontaneously. We may not even suspect or diagnose these patients in any of these viral illnesses unless we do an echocardiogram and we pick up milder degrees of left ventricular dysfunction. So they can be asymptomatic, they can present with arrhythmias, both tachy or brady. They can have symptoms of heart failure like fatigue, dyspnea, syncope, pre-syncope because of heart blocks. And in young patients, they can present with chest pain, which can be a bit atypical to that of ischemia. And some of the patients can have constitutional symptoms or can present with history of viral prodrome. If you look at patients of sudden death in young populations, if you do an autopsy and all, about 10% of them can be because of viral myocarditis. So, as I mentioned, there is a protein manifestations and they can present as a fulminant myocarditis, heart failure, or even in chronic phase. So these are some of the tests, but none of them will definitely diagnose myocarditis. They will be helpful. For example, patients of myocarditis, there will be elevation of troponins. Echocardiogram will of course document the left ventricular dysfunction. Newer techniques are being evolved for the evaluation, like tissue characterization and tissue Doppler. PET-CT can show evidence of inflammation in the myocardium. The two tests, the pillars on which we diagnose myocarditis is nowadays is one is the CMR, that is cardiac magnetic resonance, and the other one is invasive test, that is endomyocardial biopsy. A lot of importance of late has been given to the CMR. There are some criteria with which you can diagnose. So what is normally we look at the images in both the phases, that is T1 weighted images and T2 weighted images. The T2 weighted images can actually reveal myocardial edema. We can diagnose myocardial edema, which is specific for myocarditis in the T2. Similarly, if you look at the T1 weighted images, there will be early enhancement following a gadolinium, and this enhancement you can look at the ratio of the enhancements between myocardium and the skeletal muscle. If there is a preferential uptake in the myocardium compared to the skeletal muscle, that is in favor of myocarditis. And similarly, if you are looking at late gadolinium enhancement, these areas of focal areas will be of areas of myocardial necrosis or inflammation. This is an example where you can look at this is the T2 weighted, it is just showing the edema in the lateral wall of the left ventricle. This is a T1 weighted image with a late gadolinium enhancement both in the septum as well as in the lateral wall. These are some of the examples. Even Dr. Ravi Bhatna has shown an example of focal involvement of the myocardium and cardiomyopathy. This is another example of pre and post gadolinium. These are the images pre gadolinium and post gadolinium. There is actually, in this case actually, the uptake is in the subendocardium. No, more often you see it is in the subepicardium. So another test is an invasive test, which is very specific. Now actually the pillar of diagnosis is based on the endomyocardial biopsy. Unfortunately, it is not done often even in the developed countries because of the invasive nature, but this is the gold standard. For the past 2 decades or more, we were following this Dallas criteria, but it's only a histological criteria. Now people have added molecular evaluation where we can amplify and look at the viral genome by in situ hybridization or PCR amplification. That will increase our sensitivity of diagnosing myocarditis. And similarly, we can look at immunological activation by the type of infiltrative cell that is there, and even MHC upregulation is also indicative of immunological activation, by which we can diagnose this thing. The problems of diagnosing this myocarditis by endomyocardial biopsy is more often this inflammation is very focal, and biopsy is done from the right ventricle, that is from the septum. At maximum of 4 or 5 samples we take. Because of the focal nature of this disease, and quite often it involves LV alone, the chances of picking up all the diseases will be very less with endomyocardial biopsy. So to circumvent that, nowadays people are coming out with what is called as image-guided biopsies. They go on to the X-ray, you do an MR or something, and if there is a focus of inflammation, from there you can pick up a biopsy, if required, from the left ventricle. Of course, the complication rate will go up once we go into the artery and take a biopsy from the left ventricle. So there are some criteria. I will not elaborate. This is specifically for cardiologists. Initial biopsy. For a definitive diagnosis of myocarditis, there should be evidence of both inflammation and myonecrosis. If there is only inflammation, that becomes a borderline case. And similarly, they have given criteria, the number of cells, what you have to look at, the total leukocytes as well as the macrophages for diagnosing myocarditis. So what are the situations where you consider this invasive procedure? Any new-onset heart failure, especially if it is less than 2 weeks and significant left ventricular dysfunction with hemodynamic compromise, or even longer, that is subacute phase up to 3 months, in the presence of associated arrhythmia or a heart block, and failure of response to therapy within 1 or 2 weeks. Standard decongestive therapy, what Dr. Krishna Mohan mentioned, if you give and there is no response, again you consider subjecting these patients for endomyocardial biopsy. And if there is a strong suspicion that it could be because of allergic reaction, or it is part of anthracycline-related toxicity, or if there is associated hypereosinophilia, or if restrictive cardiomyopathy is suspected, or heart failure in children. These are some sets of patients where you should have a low threshold for endomyocardial biopsy. And if you look at the specificity of various tests which are useful, to us probably we can do a troponins. This has a very high specificity and a moderate sensitivity. Another thing is the indium scanning, which of course is not freely available. Echocardiogram is only indicates a left ventricular dysfunction, but it will not be able to tell the etiology. So it will not be very useful. The two tests which are possible to us is the magnetic resonance and the biopsy. This is non-invasive. If you look at both the sensitivity and specificity, they are very high. Unfortunately, even today it is grossly underutilized. The simple reason being, the disease is not suspected. Myocarditis, unless you get that in mind, you will not order a cardiac magnetic resonance imaging. Biopsy will be very useful if you are able to identify the viral germ. That is, you do apply molecular testing as well. Then the yield is better. Otherwise, you look at the sensitivity, it is close to about 50%. So you are likely to miss more than 50% even if you do a conventional biopsy. That is the limitation of biopsy, though it is a gold standard. So the present day, what is the best way to diagnose myocarditis? You incorporate all these things, tests, then you will be able to get a better yield of suspicion of these things. You incorporate clinical symptoms, look for structural or functional perturbation, but of course you have to rule out coronary ischemia either by an angiogram or by SPECT scanning. Then you look at the MR and biopsy. If you integrate all these four modalities, your chances of diagnosing myocarditis will be greater. So if 2 positives are there, it is suggestive. If 3 positives, 3 categories are there, it is probably compatible with myocarditis. And if all are there, then the chances are that it is very, very highly likely that you are dealing with myocarditis. Prognosis again is highly variable because some people will have very severe disease, some of them have mild left ventricular dysfunction. The poor prognostic symptoms are a presence of syncope, bundle branch block on ECG, significant left ventricular dysfunction, advanced New York Heart Association class. If you are doing an invasive wedge capillary pressure of more than 15 millimeters of mercury, and if there is a viral genome which is persisting in a endomyocardial biopsy. Recently they have come out with some serum levels, this is FAS and FAS ligands, which are markers of actually cell apoptosis. If, of course, we do not have this facility in India as of now. If you have the facility, then these all indicate that the prognosis of these patients of myocarditis is likely to be worse. And similarly, if you do immunohistochemistry, and if you bind a positive immunohistochemistry, these patients are likely to have a bad prognosis. And the type of cells which are infiltrated in biopsy again is very indicative. Giant cell myocarditis, which is of autoimmune nature, carries a very poor prognosis. These are the people who are likely to benefit by immunomodulative therapy. Fulminant myocarditis in the acute phase, they present very badly. They may go into shock, they may require assistance including mechanical circulatory assistance like LVADs, IABP and so on and so forth. But long-term outcome of these patients is very good. Even 10-year survivals in some of the studies is beyond 90%. So that's why these are the patients, if you suspect, you have to be very aggressive in treating them, including giving them LVADs if the facility is available. Therapy, of course, supportive, as I mentioned in fulminant myocarditis, vasopressors, IABPs and mechanical circulatory devices including VADs will be of help because the long-term prognosis is good if you bridge over the acute phase. As I mentioned by my previous speakers, these are the standards of therapy for all these patients of myocarditis. A word of caution about digoxin. This digoxin sometimes actually patient's condition can worsen because the inflammatory markers actually may rise if digoxin is given. So you should be judicious, especially smaller doses probably, or you can avoid. So specific therapy for myocarditis is very controversial. Unless you do a biopsy, you may not be able to give these therapies, because if you prove that there is a virus, then you can give antiviral therapy in the form of interferon beta. There are some studies to show that it is beneficial in the acute phase if the viral genome is persisting in the myocardium. Immunosuppressive therapies, these are double-edged weapons. As I mentioned, part of the myocardial dysfunction is not just because of virus, it could be because of the autoimmune reaction and the molecular mimicry. Then it can actually worsen some of these conditions. So if you prove that there is no viral genome, probably you can consider. There are more than 20 studies of these drugs, and differing conclusions came from these studies. So it's still treatment in evolution. Immunoglobulins, they give passive immunity. There is one study, again not much of benefit. Probably they will be of role in pediatric population, and if they are refractory to standard therapy. Immunomodulation is what you do is, you take the whole blood of the patient, you irradiate these patients, again give this whole blood intramuscularly. There is a large trial conducted with this. Again, it is of doubtful benefit. Immunoabsorption is what you do is, you do a plasmapheresis, where you remove the cytokines, antibodies, autoantibodies, all those things. Again, it is of questionable value as of now. There is an interesting thing which has come out. What came out is there is one entity what is called as endocardial fibroelastosis. Primary is seen in infants. The incidence of this disease has come down in the past 2 decades. And when they look back, what they have done is all these mothers were immunized against mumps. So they actually concluded that probably mumps virus is the cause for endocardial fibroelastosis. So they are looking at vaccinating and trying to look at all the viruses, trying to develop vaccines for these viruses, and probably we may hear something about reduction of myocarditis with these things. So in summary, if you are basing your treatment based on endomyocardial biopsy, what you have to look at is whether there is a virus persistence or not. If the virus is persistent, probably antiviral therapy including interferons will have a role. If there is no virus, probably all these immunomodulatory therapies may have. If there is no evidence of myocarditis, of course, standard treatment of heart failure is what can be practiced. So in summary, same thing. So you look at this thing. I think I'll just skip this. So what we are lacking today is a blood-borne marker for myocardial pathology. If something comes in the future, then our diagnosis will become easier. As of today, what we have is only a CMR. So short of a biopsy, we have only CMR to bank upon. So if we can have a blood-borne marker, probably our treatment, our strategy of treating will be much easier. So in summarizing, it's grossly underdiagnosed because high degree of suspicion is required, and because of a need for an invasive test to diagnose this, we are unlikely to diagnose these diseases much more often. Probably the role of immunosuppressive therapy is for giant cell myocarditis, because if you do not treat these patients, the mortality is very, very high. Very few of these patients will live beyond 6 months. And probably similarly, sarcoidosis is one which will respond very well to this treatment of steroids and all. With this, I stop. I'll be very happy if there are any queries.
Just a couple of comments. You were mentioning about mumps, and
Yes.
so about 15-18 years back, we had one patient with mumps and architis, an acute myocardial infarction. The ECG-wise infarction, anterior myocardial infarction, but angiogram was perfectly normal. So we sent for some viral studies, then it turned out to be positive. So its mumps is known to produce very fulminant myocarditis. We have seen a couple of them. Just to add on, even common cold can produce myocarditis.
Yes.
Except that it is not that bad to clinically manifest. All of you may have seen patients with unexplained premature ventricular contractions on clinical examination or electrocardiogram. Many of them are because of the microscars which have been developed in the myocardium due to a past viral infection at some stage in the life. I had many patients who had chicken pox or smallpox in childhood, and they continue to have ectopic beads after that. For 20 years, I have some of them 30 years after, they still have ectopic beads. They got used to it. If the rhythm is normal, they are very uncomfortable. So thank you very much. That was a very interesting story.
Padmanabhan, one just quick comment. Thanks for a good talk. I just want to bring up, we did some studies in people who do this binge alcoholism, weekend drinking.
Yes.
We did several MRs. Each one of them had T2 enhancement. Compared to the guys who drink 160 ml every night, the binge drinking caused acute injury to myocardium.
Yes.
I thought I would make a mention.
It's well described, sir. Yes.
The troponin, one thing which I would like to mention here is, among the biomarkers in myocarditis, there is a huge elevation of the troponins.
Yes.
That is what puts us on the wrong foot. ECG looks like acute MI, troponins are high, the patients are young, no risk factors. Many of them go with the diagnosis of acute myocardial infarction.
It is our duty to rule out coronary artery disease. Even in the guidelines, they specify that either by SPECT or by coronary angiogram, we have to rule out a
That's
coronary
right,
disease.
yeah. Thank you very much.